And we're just going to press right on.
Okay.
Okay, so you can't? Oh, hold on. He's still trying. So we're going to keep the phone lines open. So while he's doing that, David will take care of that part of it. So I'm just going to go to patient 1. Okay? And so here's my question to our audience. It's a 26-year-old female. She has a gestation period of 27 weeks. She has severe preeclampsia. Her ejection fraction is 20%. Her SaO2 is 84% on maximum ventilatory support. She's in fulminating pulmonary edema. And the plan is to do an emergency C-section and immediately go on ECMO. How do you want to cannulate this patient and why? So I'm not going to answer the question. I'm not going to know answers. I'm only going to ask the question. That's all. So when we come back tomorrow, when you give your second part, you may actually be addressing this very thing. But if you don't, then we'll throw it back up there. But I'm not giving you any answers at this point in time. So then I'm going to go to another slide if I can, if y'all don't mind indulging me just a little bit. And this slide here is very important. This is an algorithm straight out of ELSO that if you have refractory hypoxemia with a Murray score of 3 to 4, or you have refractory hypercarbia up in the top bars you see here, right there, okay? You follow the various algorithms. Hypoxemia, cardiogenic shock, no cardiogenic shock. What do you do next? If it's not cardiogenic shock, you go over here. If there is cardiogenic shock, you go over here. For all other heart failures, or if the heart failure is due to hypoxemia. Now, you see where I'm going with this, right? So this should help you answer this question. So you can find this, you can download it online, very easy to find. If not, you can just freeze frame this and download it and look at it and explore it. And look at this, and look at this, and then tell me what we should do, and tell me what you think we did. Okay, so that's all I'm going to show on that. The other thing I'm going to show is some of the, let's go to, there's some of the same slides you had. I'm not going to spend any time with this. Are you going to go over this one as well, John?
I'm going to mention
Duo?
it, but no, why don't you go over that?
Yeah, say that. You are?
I'm going to mention it briefly, but not in detail. So
no, that's fine. Well, we can discuss that, of course. So I'm going to go to, there's some more stuff. Don't be this guy. Never use VA ECMO with peripheral cannulation, FEM for pure pulmonary failure when there is no LV dysfunction. Why? Why? I'm asking the audience. If anybody wants to call in and tell me why, do it now. If not, tomorrow, we're going to go over this as well. Is it tomorrow, John? It is tomorrow, yeah.
Yeah.
Here is a TEE of a left ventricle. You see the mitral valve, and you see tremendous displacement of the interventricular septum. That ventricle is huge. Again, there's a reason for that. This patient is on VA ECMO. John, I'm assuming you're going to go over this tomorrow as well, because I think this is another very important point. And how do we manage this? What is the best way to manage this?
LV distension and LV drainage, yep.
Yep. And then
I'm talking about that.
Yep. And then I'm going to, let's go to this slide here. Here, there's your foot.
Yep.
There's your foot. The one on the left is before the SFA line, the peripheral cannulation, and the one on the right is after, and you can see it certainly got better, not perfect, but it's moving in the right direction. But you can definitely see an enormous difference. So I wanted to go here. You can even see an SFA line in here. Now, this is a test. I'm going to even, let me go to the slide. You could win a prize. Anyone can win a prize. All you have to do is call in tomorrow or call in today, if you know the answer, and answer the question. So, what are we looking at? And this is the reason. Okay? If you look way down here, right here, you can see you've got a blue line coming into it, and you can see you have another line coming into it right here. And that line, if we follow it up, is coming from right here, right? No, is that it, John? Let me see.
I think it's the one below it, actually.
It's the one below it, right here. Yes. This is the one. That's it, right there. Exactly. So this line and this line are draining back to the patient. This line and this line here, this line here and this line here are pumping into the patient. So you have red blood going this way. You have red blood going this way, right here, going in right there. And you have drainage coming here, and you have drainage coming here. But what do you notice about the color of this blood right here? This is access. What do you notice about this?
It's pretty bright.
Very much brighter, but yet it's access. So access, return, return. Why is this access bright red and this access not bright red? That's going to be the question. Tomorrow we'll bring it back up again, and anyone who gets that right, including you, John, can win a prize.
Was that the preeclampsia patient?
No.
Oh, okay.
So nope, but it's very good. You can go back and look at it anytime. Here's some of our resources. I just wanted to show you that, and I wanted to show you my granddaughter's favorite character, Mr. B. So you can take our slides off, and John and I can just have a discussion.
So Joe, why don't you at least go back to that Protech Duo Cannula slide, because I felt this today, the lecture was basic ECMO to build a platform.
Yes.
Tomorrow,
do you want me to send you this slide?
Yeah, so I wanted to, this is the Protech Duo Cannula. And the nice thing about this, and the interesting thing about this, is that different from the two that I showed, which was the Avalon and the Crescent, they cannot make this sharp of a turn. The two that I showed cannot make this sharp of a turn and make its way from the right atrium, take a hard 180 almost up into the pulmonary artery. This cannula is capable of doing that, and it takes blood in at the right atrium unoxygenated and delivers it in this configuration to the pulmonary artery. So it is a VV ECMO with right ventricular assist support. You see, it's the same as a right ventricular assist device because you're unloading the right atrium and you're bypassing the right ventricle, delivering blood for the right ventricle back into the pulmonary artery oxygenated. So this is the only cannula that can do this. Now, because my lecture was basic, I didn't want to get into this one. And tomorrow we'll have to see, because I got a lot of things that I'm talking about that are pretty involved also. But what were you going to point out when you had this on your lecture there, Joe? What was your point?
I was just going to point out, if in my lecture, what I was going to point out, and what I've done before, is that you notice that you have much lower flows. It's not an easy cannula to put in at all. This is it's not as flexible as it seems. And so it's very difficult really to get this up into the proper position. The flows are lower, but you have a lot less recirculation you have no recirculation in essence, because of the configuration of it, draining here, returning here, after two valves. Even though those valves are no longer competent because, of course, you have this cannula stuck through it. But it does really reduce recirculation. But you improve that, but you do have some sacrifice. That the flows are 3.9 liters max, and really that's hard to achieve without very, very high RPMs. I think it's very good for some right ventricular support. I don't really think it's a good first line for VV ECMO. And besides that, it's like the Tesla ludicrous speed. Its price tag is ludicrous as well. And I think that's something that just needs to change. I think
You-
they charge for their whole kit, it's about $18,000 per kit, and just the cannula, which you cannot buy here in the United States, you can in Canada, is $11,000 just for this cannula, whereas an Avalon catheter is somewhere in the neighborhood of $2,500.
Yeah, for a while we were opening the box just for the cannula. We've since stopped doing that, and we don't really. We almost act like a university setting at our hospital. We were used just about everything for the experience of it, but I think we had to stop even with this because of what you just said.
Yeah, well,
and you know, a lot of people can get by with almost 4 liters of support, but a lot of people cannot.
Yeah, but
Some
4
people
liters is
need
4
more.
liters for us. I mean, the times I've had the opportunity to be someplace that was using it. So bear in mind, I have never actually just used it myself, but I've been someplace that was using it, and they were flowing about 3 liters and couldn't go any higher because of RPMs being at essentially at a max rate. So I don't know if you saw that or not. Did you see compromised flows?
In general, as I was pointing out, it's nice that you have one cannula, you stick it in, you've got total VV support with the Avalon and Crescent, and you can flow decent with those, but it's not like having 2 separate decent sized cannulas, and the flow and the pressures you're like, wow. When you see somebody who's on VV, Fem, or something like that, your pressures and flows compared to what we always see with these single cannulas are much reduced, you know, and you can flow more.
No doubt.
And, you know, tomorrow I'm going to talk about why is that important. The patient's cardiac output that is coming through the right atrium and coming around, their cardiac output, if it is very high, which it can be in sepsis and things like that, you can have cardiac outputs of 10, 15 liters a minute, and you can only flow 3 or 4 liters. That's all you're capturing. That's all you're oxygenating.
Yep.
This is a pitfall sometimes of VV ECMO, that you can't flow more like what you're saying here.
And that's where you get into the exotic cannulations you're going to talk about tomorrow, VV ECMO or VV VA ECMO. And I think you can also treat that hyperdynamic state and actually work towards reducing their cardiac output to try and get some some oxygenated blood to the tissue. But of course, if they have vasoplegia and all these other, in fact, Dr. Simpkins is going to be giving a talk on treating vasoplegic syndrome. And they have a very good solution to that. And because it's an overproduction of nitric oxide, and if you can reduce that and clear it, then you're going to have, because of course we try methylene blue and we try all these fancy maneuvers, and very little works. Now, of course, there's the cytosorb if you think it's cytokine storm, but if it's vasoplegia syndrome due to overproduction of nitric oxide, you've got to clear the nitric oxide, and that's all there is to it. I also wanted to show you this other thing in my slides that I thought was very important. Are these the new ones? Because I never saw it. I didn't see the recirculation. That's not the ones I sent you, the second set. No, it's not. So I'm going to put this back up and go over this again. Is there anything we could do to get it up, or is it impossible? You can try? Okay. So I want to go over this again. So here is an access catheter going down. There it is, making that little loop, going like this, and this is going to the inlet of the centrifugal pump of the ECMO, and then to the oxygenator. And then here you have, coming from the outlet of the oxygenator, your return going to the patient, and here going to the patient. So you have access, access, return, return. This is blue or dark blood. This is bright red blood. This is bright red blood. This is bright red blood. So your 2 access are different color. One is dark red or blue, and the other is bright red. The question is, why and where is this cannula tip? Why is this happening? So that's my question for tomorrow. Do you want to just put up the website I want you to put up, maybe? Would that be easier? What would be easier? Huh? Okay. Hold on. He's going to throw up my my other slide deck, which has what I was looking for. So just give him a second. So that's really good, John. That was a very good basic understanding of it. I'm excited about hearing about the more exotic cannulations because, I think, we have this conversation all the time. Early intervention, you always seem to have better outcomes. If you put it in when your PA-FiO2 ratio is maybe down to, 250, 280, and you don't wait until it's 140 or less, your chances of having a more positive outcome seem to be so much better. And I think ELSO is now saying that if you have been on the vent with maximum ventilatory support, PEEPA 15, and peak pressures at 30 and above for the past, 5 days, you are no longer a candidate for ECMO because it's an unrecoverable amount of trauma to the lung.
Yeah, on one of my slides where I said contraindications, it sort of said if you're a mechanically ventilated patient, it kind of said it in a nicer way than what you just said without putting numbers on it. But I think when you get to what is the line in the sand has become, is it 7 days? It once was 10. I think it's down to 7 days on the vent, and you should have been on ECMO. A lot of people are saying we've missed the window.
Yeah,
but
absolutely.
I've seen it, but
so is it 7 days? Because I thought it was 5.
Well, it's probably reduced. At one point, it was as high as 10, and I think it was around 7, but maybe it down to 5 because even at 7, your success rate's pretty low.
Absolutely.
So now, Joe, I wanted to tell you that with the question that you're putting up there, I'm not going to answer it. I can take a stab at it, but maybe tomorrow. The thing that I'm going to do in my talk, which is interesting, is when people who come to a center like ours, and we have every hybrid cannulation, I think I've shown you a few where we've even had more than one ECMO machine on the same patient.
Yeah, exactly.
It finally occurred to me not too long ago as to when what I'm going to address is why and what are we accomplishing by doing such and such and such and such. The location of the cannulas are important, but they become and they're confusing, but it all becomes clear. I hope to bring it through tomorrow. It all becomes clear when you understand what we're trying to accomplish by adding a cannula somewhere.
Yes,
or
absolutely.
Returning an additional cannula.
Well, understanding anatomy and understanding flow characteristics and pressure characteristics is so important. And, I was going to give a talk on ECMO, staffing and specialist models and all this kind of stuff. And that's what I was really going to do today, and I opted not to. But, since you brought it up, I'm just going to go ahead and say it. I think that there are some incredibly talented people out there who are more than capable of being excellent ECMO specialists. But I feel like perfusionists, just by nature of what we do every single day, it becomes second nature to us to understand I need to drain this. I need you to put that tube there. And we just know it because it's what we do and we recognize things so quickly. I think ECMO specialist model is necessary. I think there are some incredibly talented people that can do it effectively and be very safe with great patient outcomes. But I think the best program, the best setup is a perfusion managed blended program. That's really what I believe. I know there's always turf wars, and I've seen it so many times, and it's not to anybody's advantage. John, I've seen it. I'm assuming you have too. If you haven't, if you have or haven't, you can feel free to chime in if you want to or not. But I've seen.
I had a private. I'm in a master's program, and last night the discussion was actually what you just said. The discussion was there was 30 of us that have to meet once a week, and the discussion's different every week. And last night it happened to be perfusion, ECMO specialists, and staffing models. And really, as you know, Joe, I've been doing ECMOs almost exclusively for going on almost 2 years, and I've been at least a dozen, 15 places or more with ECMO. And here, you know, as an old-time perfusionist, I never wanted our field to let go of technologies. You know, we let go of balloon pumps. We've been trying to give away ECMO for 30 years, and one day we're going to succeed. Mm-hmm. And I don't know if we're going to regret it or not. I think one day you just very well might.
Well, I don't think we should give it away. I don't believe we should give it away, and I disagree with that. But I don't want to blow. I just want to make sure I'm clear.
Yeah, I'm sorry. I don't like us giving away much of anything, but I realize it's a manpower thing. But here's the mistake that I think that we're making as perfusionists. If we were to, if there's going to be an evolution of ECMO specialists that come along and it's going to become its own field, they should be entirely under perfusionists.
Well, I agree with you.
Autotransfusionists once were entirely under perfusionists. What's happening is that they're not always being under perfusionists, and the movement is for them to be sort of under administration, under nursing, on their own, and operate as perfusionists light. Now, we keep getting drug in and drug out, and when something goes wrong, I can assure you it's going to go very wrong. Maybe it will, maybe it won't. But let's say, for example, what just happened with COVID, they shut down all the routine cases. There isn't really that much ECMO, but at least there's some. What if we didn't have, we'd be doing nothing at all. We're almost doing nothing now.
Yeah, I don't think, and I appreciate that. And I recognize that's an economic issue. That isn't my reason though, and I have really worked hard to remove from my equation that aspect of it, because at the end of the day, that's not our first objective is providing great patient care. That's it. Yeah, we need work. I recognize that, and yes, that did happen with the COVID. But I don't think that not having anything to do. Look, I mean, there's heart surgeons I know. They say it, you know. Now maybe they really don't mean it, but I think that as physicians, they probably do deep in their heart believe that heart surgeons, that it'd be great if we could literally stamp out the need for coronary artery bypass grafting. But it's still one of the most prevalent operations done in our country every year. So, you know, there's a be careful what you wish for, that they come out with Drano for the coronary arteries. You know, it's likely not going to happen. Just like I think it's highly unlikely that, you know, ECMO one way or the other is going to be the savior or demise of perfusion. Perfusion is just too versatile and too many other things coming around. Yeah. I think for me, it's blended programs make the most sense. And I was going to say this earlier, that I think there are turf wars. I do think that, you know, that some departments of ECMO specialists feel like, well, we should just be on our own. We don't need the perfusionists anymore at all. And I think that's an enormous mistake. I don't think you can legislate it. We've tried that and it doesn't work because you cannot exclude people from being able to do something. But you can make people inclusive, which is what state licensure did. But in a nutshell, it didn't do anything to protect our profession in any way, shape, or form. I think we need to get involved. I think we need to be involved. And I think that the best ECMO programs will flush themselves out as time goes on with what is the best policy. Is it to have a blended program with perfusion managing it, but specialists working with them? And that doesn't mean they work necessarily under you. It means that they work with you, but there has to be somebody who is, you know, giving direction and how circuits should be set up or what systems we should use and so forth. So it should be a collaborative effort, because I think there are some super smart people out there. But when it comes to having to figure out a circuit because you're confronted with some unique problem, as in that one that I just showed you with that where that cannula is, that requires an awful lot of experience that you cannot get from just doing ECMO. That requires the surgical understanding and knowing what's inside that chest with your own eyes and being able to basically look at the vascular anatomy in a 3D representation, looking through the patient's skin and bone and tissue and everything else, because that's what we do every day. So I think blended programs are the appropriate thing, because I think we do need increased manpower. A very straightforward, stable VV ECMO, you know, once they're on and they're stable, does not need a perfusionist at the bedside 24/7. But there should be one available for if something is going haywire, so that there's somebody there that has that innate skill, if you will, to manage those kinds of problems. That's my viewpoint. Okay, so Joe's opinion for the week.
Yeah, I mean, it's different everywhere, but is coming from home fast enough to solve a crisis that you're just describing?
Telemedicine is. You can do an awful lot with it. You can see it, and you know what to do before you even get there. You can tell them what to start getting ready. Or they can do it, you know, with your supervision or with your suggestion or whatever it may be. I think putting the patient on ECMO is the initial. Now, having one person like at a big center where you have multiple ECMOs going at the same time, I think it makes sense to have one perfusionist in-house 24/7 that's available. Yeah, that makes a lot of sense. But for the community hospitals that only have one ECMO, they can run 2 heart rooms, and they have two surgeons and only 2 perfusionists. So they can't be there 24/7, John, and you can't always find people to come in and do it. ECMO specialists are a needed asset in the ECMO world as it evolves and it becomes more and more something that we do. Something that's utilized more frequently and in places that heretofore don't necessarily have it.
Yeah, my point was not so much financial. It was more who is supervising them, and if it's not perfusionist, now it's some other department. And by the nature of human, by human nature, there's going to become a turf war.
Yeah.
Because you have a different department who is in charge of this ECMO specialist, whatever you want to call it, and they are going to want to stand largely on their own at some point, as they could or they could not. It all depends on the leadership. But my point is, you know, we've been so lucky in perfusion that new technologies that have come along have actually been added to our list of things to do rather than substituted away other ones. You know what I mean? Like, for example, the what is it? The one in the cath lab now with suctioning clots.
Oh, the angiovac.
Yeah, the angiovac, and then you have HIPEC, and these things come along that okay, you know, the perfusionist is doing them, rather than technologies that have substituted what we do out. We've actually been added on to a lot more than
absolutely.
And so in that way, you know, we've been lucky.
Absolutely.
And the manpower thing always rears its ugly head. You know?
Yes, absolutely. But again, I think that the most successful programs will be the ones that use the interdisciplinary blended approach towards the program, and I think the ones that people who may be very smart but believe I don't need you, given and not respecting. You know, we want to respect them and their knowledge base and their experiences, but it has to be a two-way street. And when one of those directions doesn't work for some reason, then what happens is their program doesn't do well because their outcomes are not very good, and then they make change. So that's kind of, I think, how it all ends up evolving. But anyway, with that said, let me go to my slide. I wanted to point this one thing out. On recirculation, there is a Transonic company up in New York Ithaca, New York, makes the ELSA. And this is a fascinating device that I've had an opportunity to use, and it is incredible. So regardless of whether you're doing dual cannulation or single cannulation technique, you give a single injection here of 20 cc's, and it measures the recirculation as you're pumping the blood back in and accessing it back down with sensors that are placed on the venous and the arterial systems. And what you get is a readout that looks like this. So it does two things simultaneously. This is just set at recirc, but it actually measures intra-oxygenator blood volume. So you know if your oxygenator volume is going down, the only thing it would be is clot. So you know that you're losing surface area in your oxygenator. But in this particular case, you see that the recirculation is 50%, meaning that your effective flow, now this is on a child, obviously very small flow. You have flow of 640 milliliters a minute, but you can see your effective flow is only 320 milliliters a minute. And that would be the same if this was, 5 liters and it was 50%, then this would be 2,500. So you can see what your effective flow actually is and what percentage your recirculation is. So you can adjust your cannulas to get your recirculation down below 20% or below. I've seen it as high as 38%, and I've also seen it as low as 15%. And let me tell you what, there is an enormous difference in your arterial saturations when you have this number as low as you can possibly get it. I've never seen it below 15%, but I have seen 15%, but I've also seen as high as 38. This was just an image that I got off of the internet, and it's pediatric. But it's very simple to use. I'll go back and show you again. The meter sits on the table. You throw your arterial sensor on, your venous sensor, it's all external. You give your 20 cc bolus of well, not necessarily 20 cc's. It's a set amount. So in a baby, it would be a lot less. In an adult, it would be 20 cc's. So keep that in mind. But basically, it takes into consideration how much volume is in this line right here. The saline goes up, and whatever part of that saline immediately comes back gets picked up right here, and then gives you the calculations. Really interesting technology, and I highly recommend anybody watching this program go to transonic.org, or transonic.com, transonic.com, and take a look at the ELSA. I think it's a very, very powerful tool that should be used. I'm done with my slides, David, thanks. Okay, perfect. John, any final thoughts?
Well, what you just brought up there on the ELSA, I am going to touch lightly on that because I agree with you that it should be used pretty much. It should be in every ECMO center.
Yeah, I think it should be a standard of care. I don't think you should do ECMO without it.
Yeah, and I know more and more are acquiring that. But tomorrow, maybe you can have that slide and some other similar slides, and we can interplay back and forth. I don't have a slide quite as good as the one you just put up there. I'm still polishing up part of that lecture, but that is something I wanted to touch on. Recirculation is what I wanted to touch on. The pitfalls and how to cure some of these things that we talk about, like north-south syndrome. What is the cure for that? What can we do to fix it?
Oh,
we
it's
don't have to
it's
live
a nightmare.
with it.
It's one of the most insidious problems that you can have. And there's not a lot of ways to fix it. I know there's ways, but there's not a lot of ways to fix it.
And we're going to go over a few. Yeah, right. Some of them are nice thoughts, but they don't work.
Mm-hmm.
Absolutely. But there are ways to fix it. And I like I said, I want to try to point out to people, step back and look at all these different hybrid cannulations. Rather than sit and memorize what each one is doing and why, you can actually digest. If you know what the person, the surgeon or whoever did this high-pipe cannulation was trying to accomplish and what problems they had, you'll see that what they did resolved and fixed the problems, and that's why you're doing certain things. And
Absolutely.
I think that'll make things a little simpler.
Well, I want to add something to what you just said, if I can, please. And that is, not only is it something, you know, the Harlequin syndrome or North-South syndrome or differential hypoxemia syndrome, whatever you want to call it. I mean, I know there's all kinds of different names, but it's not just how do you fix it. It's so important to know how to recognize it. That's really important, because I've seen it go unrecognized by a lot of really smart people.
One of the sections that I'm going to talk about is ECMO monitoring. How can you up your game? That's actually the little section that I called it, because I think there's some simple things we can do with some simple machines that most of us have out there in our hospitals that make a whole lot of sense, and a lot of times they're not used very much.
Yes, agreed.
And I'm going to talk about a couple things like that.
Agreed. Perfect. Very good. Okay. Well, with that said, I think we'll go ahead and end for the day. Looking forward to seeing you tomorrow again at 5 o'clock Central Time. Please, if you haven't already, go to slido.com and make sure that you do the survey. John, if you could do that too, I'd appreciate it. You can go back and watch the video and just put your phone QR reader up to it. It'll take you right to it. Or just go to slido.com and put in what is it? It's perfweb C30-8, right? But it's in the video. You can go back to the very beginning and see it, because this video will stay up, obviously. That's it. You know, we're just looking forward to seeing you tomorrow. And thank you again so much for taking the time out of your busy schedule, your day off, trying to, you know, probably take a break and relax. I know you work all week, but we appreciate you, and all of the staff, all of the audience out in web world appreciate you too, John. Thank you.
All right, Joe. Thank you so much.
And we'll see you tomorrow.
Thank you.
Bye-bye.